Greetings to everybody, and good morning, good afternoon, good evening, wherever you are. And it is a pleasure for us to host this webinar, which is a collaboration between Niche, which is a NITAC support hub based at the University of Cape Town, and WHO, that we collaborate closely to host vaccinology webinar series on topics that are relevant to the work of NITAGs, especially in Africa. And in addition to our collaboration with WHO, we've got many other partners that we work with. And for today's webinar, the focus is on vaccine switches. And most of you know of possibly different types of vaccine switches that has happened in your country, or it's being planned to happen in your country. And we thought, given the recent development on vaccine switches, especially for the measles containing vaccine, 10 dose to 5 dose vial switches, as well as the availability of the new wholesale pertussis hexavalent. It is the right time to have this kind of webinar for us to discuss some of the rationale related to these kind of switches, and also get to hear from partners supporting different countries on some of the tools and resources that are available to support your country in undertaking vaccine switches, and also hear from Gavi in terms of the kind of support that is given to countries with respect to vaccine switches, and then go deeper into the specific of the MCV 10 dose to 5 dose switches, as well as the specifics of the pentavalent to hexavalent vaccine switches. So it is a pleasure. And as an introduction, my name is Benjamin Kagena, and I lead the project that we call NITAC Support Hub. I know most of you may have heard about it, but just to explain, this is a project that is funded by Wellcome Trust. And the idea of this project is, in collaboration with WHO, is to provide scientific support to NITAGs with respect to evidence-informed decision-making. So for this webinar, before we start, we are very lucky to have excellent speakers who are going to talk to you on this topic of vaccine switches. Just a bit of housekeeping. We are using an interpretation which is powered by artificial intelligence, or AI. So if you go at the bottom of your Zoom window, and this is the button second left at the bottom from your right. You'll see there is an interpretation icon. So if you click it, you'll see there are 3 channels. There is English, Portuguese, and French. So if you choose your preferred channel, if you do not want to hear the background sound of the original sound that is being interpreted, then you can click again that channel after you choose your preferred channel and go and mute the original sound. But if you are required to speak, then you need to remember to go and unmute the original sound, because then your sound will be original and the one to be interpreted. And maybe, Alana, as we do the welcoming, you could just share the agenda just to refresh the delegate on the agenda for today's webinar. But just to get started, I'm going to invite Sidi, and I will request all the speakers just to spend the very first 1 minute introducing themselves before they get started with your presentation. And after that, it's up to you. You can either switch off the camera or you can keep it on for the rest of your presentation. And after CD, then we're gonna go straight into the next speaker, who is Amina from Gavi. And Amina, you're also going to just switch on your camera, introduce yourself briefly, and carry on with your talk. And lastly, for the first session, we're going to have a recorded talk by Maggie from Linksbridge. So this is a recorded talk. So Alana is going to play the talk. And then after that, we're going to have a moderated question and answer from the three talks. And just to say that you can also type your question or comment on the chat. And we do have Sebiso, who is collating all the questions, and she's going to share that on the screen for the speakers to engage with you on your questions or comments. So without further ado, I'm going to hand over to Sidi to take us through the first talk of this webinar, which is a snapshot of past and present of vaccine switches in Africa. Thank you, and Sidi, we look forward to your talk. Over to you, Sidi.
Thank you, Ben. So my name is Sidi Njai. I'm an immunization officer, expert in public health and vaccinology. And I'm in charge of supporting the NITACs in the Afro region and working with the NITAC support hub based at Cape Town University. So working with Ben since years now. And so this is a good collaboration, and we started collaborating also with Sabine on the hexavalent vaccine switch in the Afro region. So are you seeing my slides? Okay.
Yes, we can see your slide. Sidi, if you could put it on present, perfect.
So this is a quick introduction to the webinar, having a snapshot on the vaccine switch in Africa, but generally. So when we are talking about vaccine switch, it's the vaccine switch occur when a vaccine for a particular indication is substituted by another vaccine, but covering the same indication for same diseases, but with different product attributes. So this can be antigenic or coverage, or changing in the formulation, or changing the number of doses per container or per vial. So this is the main definition for vaccine switch. And the vaccine switches can be diverse and can also develop. So the country can switch a vaccine, and when implemented it, they said that they show that it is not really what was expected, sometime in terms of cost, and they can go back to the other. So the first one is the serotype coverage switch. You can switch changing the serotype of vaccine. For example, we all know the switch occurred in 2016 from the TOPV to BOPV, but also the PCV7 to PCV10 and to PCV13. And some switches from PCV13 to PCV10. Also, we can have a combination of vaccine switch, switching from DTP to pentavalent, think this was the first switch in the routine immunization in the African region. When Gavi started to support countries, many countries switched from DTP to pentavalent, and now we are so projecting to switch to hexavalent vaccine in the coming year. The switch also can be a route of administration switch from OPV to IPV. So this is also a kind of switch we can that can occur in countries. The dose per vial also, I think there will be a presentation on the MR10 dose to MR5 dose that the countries are expecting to, some of the countries have already switched to MR5 dose, and some others are considering this question. And we can have also the vaccine schedule switch. For example, the PCV 3+1, so the 3 first doses at 2 months, 3, 4 months, and 6 to vaccine the PCV switch 2+1, the 2 first initial doses in the first year of life, and second dose in the start of second year of life. But when you are switching, the vaccine switch involve many factors that aim to improve the public health outcome, to optimize the resources, and to address specific challenges within immunization programs, specifically in the low-income countries. So it can be improving the protection against infectious diseases. When you want to cover more antigen in your routine immunization, we saw that many countries now are switch from PCV 7 to PCV 13 and or to PCV 10. But for the course, sometime they can switch from PCV 10 to PCV 13. And also, to enhance immunogenicity, we thought that many, when we used the main Afrivac in the continent, starting by 2010, we thought that for years now, we have no serotype A, but there is emerging serotype like the X. And the manufacturer were obliged to really find the way to have a multivalent, including the X. And the switch also will optimize budget in resource allocation. So the cost effectiveness is really something you need to take in account. The reduction of doses, so that at the beginning of HPV vaccine, it was 3 doses, but with the generation of new evidence, so that 2 doses were effective, and now single dose is likely more is effective as 2 doses. And now many of the countries in the African region are moving from the 2 doses to the single dose. But also there is a consideration for the increase of supply chain efficiency, switching to multi-dose vial that can reduce the wastage and improve the inventory of the supply chain management, but also the addressing vaccine shortage. For example, during the IPV shortage, some of the countries with evidence that fractional dose were effective, so they switched it to the fractional dose of IPV vaccine to really minimize the vaccine shortage. One thing also to consider is responding to changing the disease epidemiology. We thought that during the rationale for the TOPV switch to BOPV is that the type 2 of poliovirus vaccine were considered eradicated. So there were no reason to continue vaccinating with the TOPV. So that was the rationale to switch to the OPV vaccine. But also, as I said, you can have emerging strains, like for the Neisseria meningitis, when we have the emergence of the X and other serotypes in the African region. So the countries are now considering to switch to introduce the pentavalent conjugate vaccine against Neisseria meningitis. Enhancing vaccine safety also is a consideration to take in account to reduce adverse events. For example, switching from the OPV to IPV, and I think this is really the current discussion at the global level for polio eradication, and this will be a topic for the next stage meeting, how for recommendation to switch to do the cessation of OPV and the switch to IPV vaccine. But switching vaccine also will simplify immunization schedule. Combining vaccine, also harmonizing schedules also. When you are switching, you need to take in consideration these things. So there is some challenges you need really to take in account, really specifically in the low income countries. The supply chain issues is one thing to take in account. The cold chain management, because some of the vaccine require strict temperature control and more space with limited refrigeration infrastructure in some countries. So this need to really to be taken in account. In the public perception, like the misinformation or lack of awareness, can lead to vaccine hesitancy and healthcare professional acceptance also for the switch. For example, you want to switch from MR to MMR. So there are pro or cons, and the program need to take in account that also. The high cost of the vaccine, if you want to switch, you need to have maybe a less costly vaccine to switch for an equivalent of efficacy and effectiveness. You need to find that. But sometimes the cost can be higher, but more effective. So the decision need to be taken in account. The sustainable financing also need to be taken in account. The distribution, efficient distribution system are needed to ensure that the new vaccine reach all parts of the country, including the remote area, specifically to considering the equity reason. In the surveillance system also, this is a challenge. We need a robust system to monitor the impact of the new vaccine to be introduced in the countries. And also data collection, you need to reframe or to customize your data collection tools to really evaluate the effectiveness of the vaccine and also make so necessary adjustment to your monitoring and evaluation tool. Why not, if the evidence are not really sufficient, the country can consider to have the kind of generating evidence on the vaccine, specifically on the vaccine effectiveness. So the measures I want to highlight here to the NITAC is the decision to switch vaccine is complex, needs to consider factors in terms of public health, in terms of cost effectiveness, in terms of supply chain, in terms of logistic, safety, and acceptance of the switch. And these need, the country need to have a planning, a very strong planning for this switch and engagement of the multiple stakeholders, including the NITAC. In the meetings, I said to the API manager that if you have a Dochevo and you have a Jaguar, you will not take the Dochevo and let the Jaguar. So you have a NITAC. Let's use the NITAC to help you making the decision. And you need also continue monitoring. This is essential for successful implementation and maximize the benefit of the switch for the immunization program. That was my last slide. Thank you.
Thank you so much, Siri. We now go to Amina, who is our next presenter. Siri, we're going to come back to some of the issues you've raised during the Q&A. Amina, lovely to see you, and over to you.
Good morning, Benjamin. Good morning, everyone. Thank you so much for the invitation to this very critical webinar. My name is Amina Bouathmeni. I'm the program manager for the Measles and Rubella program at Gavi, and I will be presenting you today with an overview of the Gavi support for vaccine portfolio optimization and vaccine switches. I don't know if you can see my screen.
Not yet, Amina.
So I can. One second.
Are you able to? Okay, now it
Can you
looks
see
like.
my screen now?
Yes, we can see it now. If you can put it on the presentation mode, that will be
Yes.
great.
One second. Great.
Excellent.
So as I said, we'll present you today with the Gavi support to vaccine portfolio optimization and switches. And here, with my first slide, we can see that over the years, the Gavi vaccine portfolio has really expanded more and more to include more and more vaccines, and more are to be added in the pipeline over the years. And with this, we also have a variety of switch options and schedule alternatives that are presented with potential benefits, which include, as also the earlier speaker was mentioning, potential benefits around programmatic complexity being reduced or optimizing cold chain space, but also improving efficacy, effectiveness, and safety, improving coverage, reducing cost, but also supplying, making sure there's enough supply availability. And all of these options are available, and countries make their own decisions around what is the potential benefits of each product, presentation, schedule, or use that is fit to their context. And here is really where vaccine portfolio optimization work comes in Gavi to provide that guidance and orientation to make those decision-made, to those informed decisions with key criteria to make those assessments. Here, it's really a brief overview to say that this portfolio optimization work is also evolving as we move and transition in the 6.2 strategic period in the coming years. It's really kind of transitioning from vaccine-specific information shared with countries within standalone support to a more cross-portfolio view, consolidated view to really map out all of these options across the vaccine portfolio of a given country and find efficiencies whether programmatically or financially, that would benefit the country in a specific opportune moment that is considered appropriate. It also bears in mind really the impact on health on the market across all Gavi eligible countries, beyond that one country, but also really looking in the immediate and long-term market implications to ensure that we still continue to have long-term access to affordable and accessible vaccines. Really to give a brief overview that really, vaccine portfolio optimization and switches goes beyond the country context or beyond the country's settings benefits to have systemic impact on multiple other dimensions, namely the market health, as I was mentioning. Really, it's really seen as a holistic kind of architecture that influences other parameters, the supply security, market competition, pricing, and really drives the investments in health towards a specific area, specific disease control, innovation, to really have a systemic impact beyond one country to really the full landscape. And here, more specifically, we're really looking at what are the opportunities for countries, what is the right timing for them to consider switching products, switching presentation or schedule or use to conduct this exercise around the vaccine portfolio optimization. Of course, countries are always encouraged to explore these options of optimizing their portfolio at any given time, and switch requests to Gavi are welcome at any time in the year to maximize country-specific programmatic and financial context, of course. But we do, see specific time points that are very crucial to consider and to leverage when wanting to consider a switch and then making that decision. So when a country really works on updating their national immunization strategy, that is a key opportunity, because part of those decisions on which product, which presentation to be used, which is the appropriate schedule or use for a given vaccine, is really part of that exercise of establishing a long-term plan, and that is the national immunization strategy. Same goes for the vaccine, submission of a full portfolio planning to Gavi, and that is also a long-term plan over a number of years where those decisions need to be made, and that's also a very critical time point in the planning of a country. It can also be within a context of a standalone vaccine application support, whether that's for routine support or campaign implementation, where a country would consider a switch also as a potential entry point. Other considerations that country usually opt for is that when there are changes in their co-financing obligations, and that entails changing in the transitioning out of Gavi support, for example, or changing in the phases of Gavi support, moving from preparatory transition to accelerated transition, for example. Other context-specific elements as well around fiscal space and cost and financial considerations, but also epidemiological data might also drive switch decisions in a country. Other factors related to manufacturers include supply availability. So, for example, if we have a new product coming to the market, that also might be a good time to reconsider whether we should opt for that new product or stay on the older product. Changes in pricing, wastage rate is also a key factor to take into account. And might trigger that decision to go for a switch. And then thirdly, technical guidance, obviously, and new evidence coming out of the WHO recommendation. This can be driven by SAGE recommendation or position paper issued by WHO, or a new product being pre-qualified. Coming down to really what Gavi's support to vaccine portfolio optimization really consists of, and how do we really guide and orient all those decisions around the switches, which should be suitable to the country contexts. First, I would say it's really about ensuring there is access in a transparent way, openly to the available information that is there. And here we can see a snapshot of the Gavi menu, which is the detailed product profile that exists and is publicly accessible at the Gavi website. So it's really laying out there all of the options available in the Gavi portfolio of products and presentations for a country to look at, to consider, and to decide on which is most fit for their context. Second is really supporting an evidence-based impact assessment and presenting this framework, which I will go into detail further in my next slide, which really considers key elements to make that decision about the switch. And finally, the actual implementation support that is given to countries by Gavi in terms of mainly the switch grants, which is a one-off investments. Again, I'll speak to it later, particularly in the context of MCV switch, and supposed to cover implementation costs of the switch. Secondly, we have technical assistance that is also provided to countries to support the planning and implementation of the switch, and more broadly, general guidance around the switch that is also possible and accessible to countries to optimize their switch opportunities and plan adequately and effectively for switch implementation. And of course, a lot of all of these elements and further details are available in the Gavi vaccine funding guidelines, also accessible publicly in the Gavi website. Going in more details and focusing closely to the really looking at this framework that was established by Gavi in terms of the assessment of the impact of the switch. Again, multiple dimensions, as the previous speaker was mentioning, are key to consider and to really think of very thoroughly before making a decision of the switch, to weigh in the implications, the potential impacts, and also weigh in the trade-offs that need to be considered when a country comes to make that decisions around the switch. It can be around efficacy, effectiveness, and safety, of course, reviewing the latest up-to-date data that is available. It can also be around the ease of use. Is it more practical to have 1-dose schedule or 2-dose schedule? Should we consider a 10-dose vial or 5-dose vial, which is easier to train the healthcare worker? So all of these things are important to consider. The coverage as well. Are we seeing coverage increase if we do a switch? Cold chain and storage capacity is also a key element to also consider and make sure that there's enough planning of cold chain capacity that will accommodate for the switch, for the additional space potentially, or the reduced space that will allow us to get cold chain capacity increase. And then 2 other considerations were added based on guidance from WHO dating from 2014 around the financial sustainability. Cost is obviously a key criteria. Is it going to be cost effective, or should we budget for further funds to accommodate the switch? And then finally, and very importantly, supply availability is a key element to make sure that we continue to consider the market health, that we still ensure we have accessible vaccines that are affordable to countries, both in the immediate and long term, for the sustainability of the market. The vaccine funding guidelines, as I mentioned, are a key document that include a big section around this work around the vaccine portfolio optimization and switches. All the information there is available publicly for countries to access. And more specifically around the switch request submission, we have a checklist of the required documents. This includes a switch request form, which really outlines the key elements around the planning, the potential anticipated impact of the switch, the cold chain capacity, all those kind of practical operational steps that the country will need to justify. Secondly, the NITAG recommendation and ICC and other managing bodies kind of endorsement is important, but also not very it's very specific to each type of switch. For example, for the MCV switch, it's not mandatory. It can be optional. A country can add it, but it's not necessary. Switch implementation plan, of course, really to lay out the next steps, the chronogram of the key activities, to make sure the switch is well planned and really thought through. A budget is important as well, a very detailed budget that also is similar as other budgets for other grants that are provided by countries. And here it's only applicable when a country submits a request for a switch grant, and I'll also mention the switch grant in more detail later in my presentation. And then really, because sometimes we see indeed a difference in cost and implication on the co-financing, a 5-year co-financing scenario is to be included. That is usually part of this request form, which needs to be signed by both the Ministry of Health as well as the Ministry of Finance. It's also important to note that, of course, countries can come in with a switch request at any time. Some vaccines have their own specific switch requests that are not generic, for example, for MCV switch, for HPV, for IPV, Hexa, and I believe that is and HV have their own specific vaccine sections and their own specific switch request form that are tailored to the program and the specificities of that program. Here, just really one slide to give an example of the process of the application for the MCV 10-dose to 5-dose presentation switch, really outlining the key steps that country usually follow from the decision-making of the right timing of the whether a switch is recommended, is applicable in a given country context, to all the way to the implementation of the switch. So really, first step is key. It's about making sure we identify the right suitable time to implement the switch, and that happens through engagement with key stakeholders to understand both at national and subnational level what will be the implication of a switch. Is it appropriate? Are we looking at the right timing? But also keeping in mind the stock data around where are we with the stocks. If we have higher stocks, maybe we should wait until we exhaust that stock before switching to a new product. And then secondly, also very important, it's what I was mentioning earlier around the switch assessment framework. Countries really need to look at the decision around the switch, considering key factors, cold chain capacity, incremental costs, potentially impact on wastage and coverage through that switch assessment framework. And this is all to make sure that the decision is evidence-based, it's well-informed, and it's really keeping in mind all of those key considerations. And here's also an important moment because whenever there's a need for technical assistance, this is the right moment for countries to consider also looking at WHO, UNICEF, and other extended partners to support this impact assessment in itself, but also with the switch request preparations. And that is preferably supposed to happen a year before to make sure there is sufficient time allocated for technical assistance deployment in country. Third step is really getting consensus with everyone on board in terms of the decision-making bodies, whether that's MOH stakeholders, NITAGs, ICC, and this is also, of course, with the heavy involvement of the Gavi senior country managers to ensure we follow the critical steps ahead. And then an important key step, of course, in terms of demand planning is securing the supply availability with communication that is done in a timely manner between UNICEF country offices and UNICEF SD. Fourth step, obviously, is the submission of the switch request to Gavi, with obviously the sign-off is mandatory for MOH and MOF if it's requesting a switch grant. And for the implementation as a final step, of course, it's preceded with plan. Well, it is supposed to be really, really well planned, well prepared to make sure that we reap off the potential benefits of that switch and that it's really producing a good uptake and potential benefits that we are anticipating. And then my final slide is really going a bit in more detail around that switch grant, which I said is a one-time investment provided to countries to submit when submitting a switch request based on their on the needs. It's really to cover the cost implementations of the switch, whether that's a presentation switch, product switch use, or schedule switch. It's available to all Gavi eligible countries. That is, for example, in the case of MCV, even if a country is not supported for measles or MR in their routine program, if they are self-funding, for example, they are still eligible for the switch grant. The switch is programmatically and financially justified. They do benefit from the switch grant. And then in terms of the ceiling, it's 25 cents a dose per infant in the birth cohort, or a lump sum of $30,000 with the exception of HPV, which is at 80% cents. And then final kind of view of which activities can be supported with a switch grant. It can really be around the switch planning and implementation, and it can cover training costs for healthcare workers on the administration of the products, printing and developing and distribution of new materials, on guidance and tools around that new product and new presentation, but also all that logistics around the monitoring, the distribution of the stock, and potentially the gaps in the cold chain. With this, I'm finishing my presentation now, and I guess next step is to open it up to questions. Thank you.
Thank you so much, Amina. We will come to the question and answer session after listening to the recording from Maggie, who works with Linksbridge. Alana, do you want to put the recording to us, please? And just to say that Elizabeth, who is one of our staff members, has sat with Maggie on this presentation, so she will be able to address questions and comment that are raised based on this recording. Right, Alana, over to you.
Sorry, Ben, just give me a sec. I just want to see if I can solve the problem here.
Okay.
This presentation is focused on tools and resources to support countries planning a switch from the measles or MR vaccine in the 10-dose vial presentation to the 5-dose vial presentation. It's one product optimization intervention that can help to improve vaccination practices during routine immunization. By now, many of you are already familiar with the case for switching to the fewer dose vial presentation for routine measles and MR immunization. Healthcare workers are hesitant to open a 10-dose vaccine vial due to fear of wastage and stockouts. It often happens that a health worker will turn caregivers away if only a small number of children are present for vaccination. They may only give the measles vaccine on scheduled days, sometimes only once or twice per month. When health centers are stocked with 5-dose vials, healthcare workers can open the vaccine more easily and hold smaller and more frequent vaccination sessions. A well-known study from Zambia provided clear quantitative evidence for this fact. Comparing health centers that were stocked with 10-dose vials to centers stocked with 5-dose vials, MCV1 coverage was 4.9 percentage points higher when health workers had access to a 5-dose vial, and MCV2 coverage was 3.5 percentage points higher. Even without any additional training or policy changes, healthcare workers reported being more likely to open the 5-dose vials and to vaccinate children outside of scheduled vaccination days. And the intervention was found to be very cost-effective. The vaccine wastage rate was 47% lower in facilities that were stocked with 5-dose vials. And so after adjusting for wastage, the vaccine price per MR dose was only 3 cents higher. Research on 5-dose vial usage in countries across Africa, Asia, and the Middle East all have similar themes. The intervention improves coverage, decreases wastage, it's associated with only moderate cold storage increases, which most countries can accommodate for. It's cost-effective and preferred by healthcare workers. Currently, there are 17 countries in the WHO Afro region using 5-dose or fewer dose vials for routine immunization. If we apply the coverage change increases that were found from the Zambia study, around 246,000 additional children are getting reached annually in these 17 countries because healthcare workers have access to fewer dose vials. If all the remaining countries in WHO Afro region switch, around 1.2 million additional children could be reached each year with the first dose of a measles or MR vaccine. And by the way, that estimate may actually be low, because Zambia's baseline coverage was already 82% before the intervention. If countries start with lower baseline coverage, they can likely expect even higher coverage gains. And remember, health centers in Zambia saw a 4.9 coverage bump even without any additional training or guidance. If countries take the switch as an opportunity to refresh healthcare workers on open vial policies and give specific guidance to encourage vaccinators to hold more frequent measles sessions, then the impact of this change could be even more significant. The good news is there's been a lot of momentum for countries switching to the 5-dose vials. In 2020, Africa's RITAG formally endorsed the recommendation that all countries switch to using 5-dose vials for routine immunization as one intervention to catch up on coverage in the post-pandemic period. Between 2025 and 2026, at least 10 more countries are planning to implement the switch, including highly populous countries like Ethiopia and Nigeria. There are a range of tools and resources available to support country decision-making on the 5-dose switch. You'll find guidance and materials available on the MCV 5-dose page on TechNet or using the Dropbox link provided in this slide. You'll see a range of research and evidence documenting different countries' experiences with using fewer dose vials for routine immunization. You'll find guidance and materials from Gavi, including the switch application form and example implementation plans from countries. There are step-by-step materials describing when and how to switch. And you'll also find a very useful Excel-based assessment tool, which you can use to assess the potential impact of switching on things like coverage, wastage, cold storage, and costs. I'll do a brief demonstration of that tool now. So here you'll see the Excel-based tool. It has 4 tabs. The first is a README tab with a description of how the tool works, sources for various data inputs, some limitations and descriptions of outputs and impact. You'll select the Inputs tab and provide country-specific information. First, you select the country. We'll select Ethiopia, which is planning to switch in the next year. You'll see the target population size is automatically populated based on UNPD data. Next, you'll select the country co-financing status. Ethiopia is in the initial self-financing phase. You'll select either a % of the vaccine price or fixed amount based on the country's co-financing status. Countries in the preparatory transition or accelerated transition phase will select a % amount of the vaccine price. Countries in the initial self-financing phase will select a fixed amount. Ethiopia uses the measles vaccine, which is 20 cents per dose. Coverage inputs are automatically applied based on WUNIC data. Next, you can select your wastage assumptions. WHO and UNICEF assume that 10-dose vial wastage is 40%. 5-dose wastage goes down to 30%. You could also test the Zambia study's assumptions, or you can input your own wastage assumptions. If, for example, you know wastage is much higher in your country, you might test what the impact could be. For now, I'll use UNICEF and WHO's. Next, you'll select program costs. That includes non-vaccine annual costs per dose. The Zambia study found 5 cents as non-incremental vaccine costs, but these costs are really very specific to country, so you might want to conduct your own assessments to determine appropriate program costs. Finally, you select the measles vaccine, current product and product to switch to. Ethiopia is currently using a 10-dose vial for measles and switching to the 5-dose vial for measles. You could also see what the impact is switching from MR 10-dose to MR 5-dose. Next, you can go to results. Here, you'll find a range of outputs, descriptions, and interpretations, and some helpful charts as visuals to show what the total required supply might look like with a 5-dose switch, cost impact, wastage adjusted cold chain impact, total cold chain requirements, and other details. The impact tab describes these outputs in clear sentences, and you can take these sentences and insert them directly into the Gavi application. Again, you can find this resource and many more on the public measles and measles rubella 5-dose vial TechNet page, or on this Dropbox link. And materials are available in English, French, and Portuguese. My colleagues on the call will be happy to answer any questions, and you can also reach out to me at Linksbridge. My email address will be provided. Thank you very much.
Right, excellent. So those are the 3 talks for the first part of the webinar. And just to thank Maggie in absentia. So maybe I can invite the 2 speakers to switch on their camera, and also Elizabeth, you can stand in for Maggie to address any questions related to the presentation on the resources and tools available. So Sebiso, there are some questions that have been put on the chat. All right. So the first one goes to Amina. Could you outline the specific process? Just go back, Sebiso. Amina, this is to you. Could you outline the specific process Ethiopia needs to follow to access the switch grant for transitioning from MCV10 to 5-dose vials? And then additionally, what best practices would you recommend for optimizing the grant use, particularly in areas like healthcare workers, training, updating guidance materials, and addressing potential Sebiso, if you could keep it static on that, thanks. Updating guidance materials and addressing potential cold chain gaps. All right, and are there common challenges other countries have faced in utilizing the grant effectively? Over to you, Amina.
Thanks so much, Benjamin, and well, thank you so much for the questions. Very relevant and very much needed. As much as we try to simplify processes at Gavi, and we try to tailor the processes to the country needs, and it's also always important to keep in mind the country context, the country needs, and to make sure that there's effective engagement with the relevant stakeholders. So in the case of Ethiopia's switch, more specifically addressing the first questions around the switch to from 10-dose to 5-dose vial presentation for the measles containing vaccine. If you don't mind keeping the questions on the screen, I would say it is really following the same process steps that I was presenting earlier in my presentation, with the 5 key steps around determining if the switch is needed, when the switch is needed, when is the right timing for it, and then really gathering the evidence, following the impact assessment framework, and really compiling all the reads on all the evidence to support the switch decision. And I think one key item here, given that Ethiopia, it's a very large volume country. So a key step is really making sure that the demand planning is done in an efficient and well-planned way, because the volume is very considerable, and the accuracy of the forecast and the accuracy of the timing of the switch needs to be very well planned. So that communication around the timing of the switch, where are we with the stock levels currently with the $10 presentation, when's the right moment to switch, is very important to ensure that we don't have either stock outs or overstock of the old presentation. And then here comes in really the communication with the UNICEF country offices and the UNICEF supply division to ensure that the planning is done within the needed timelines, to ensure that we meet those timelines that we set in the first place. The switch request in itself is not different from any other switch request for the MCV, and the same process really is followed to make sure that we have the consensus, we have all the required documents that are submitted. Again, it's also a switch that can come in at any time in the year. It's always welcome. And again, it's really, and maybe I have not really mentioned it, but for the MCV switch, and it's an internal review. So teams in the Secretariat of Gavi, alongside technical partners, review the switch application, and then there's experts that really come in to evaluate it and grant the approval. That is the review step of the application submission that is done. And then another consideration around the timing is really to make sure that the switch application request comes in within adequate timelines that would meet the implementation timelines. So we usually recommend at least 8 months from the application submission to the implementation date that is intended by the country, again, to accommodate sufficient planning and preparation for that switch. Again, it's a big country, the program is very has a lot of impact, and the switch will see a lot of impact. So as much as we put in efforts and time to adequately prepare, as better the results of the switch, as better the uptake will be. So really, timing is a very good consideration. Demand planning, forecasting, and those quantification is also very key. But really, the steps are the same. The switch grant is also applicable for Ethiopia. The technical assistance is also applicable for Ethiopia. And then going to the second question, conscious of time. So really about best practices to optimize the grant's use. Again, keeping in mind those key parameters, key factors of the assessment of the impact of the switch. What are the potential benefits? What are the trade-offs? Are we seeing an increasing cost for the countries? Do we need to allocate further budget? Areas around training, updating material, potential cold chain gaps is also very important, and needs to also be factored in at the assessment and the decision making of the switch itself. It also really depends on the switch. Is it a schedule switch? Is it a presentation switch? And what are we changing? Are we changing? Is it similar? Is the new product similar to the old product? How extensive is the training going to be for the healthcare worker in terms of changing in the practices and the administration mode that needs to be done? So it really needs to be tailored to the switch. It really needs to be tailored to the immunization program. The guidance material as well need to be adapted to the context, to the use of that. The cold chain capacity, again, like it's really specific to the country's context. Sometimes we see actually an increase in the cold chain that is needed, and that's why that assessment is very key to make sure that we are within and we accommodate that cold chain need when we plan for the switch. The challenges faced, I would say, we keep learning, we keep improving. implementation of the grant is always going to be context specific, country specific, and we keep learning. We keep having a lot of countries switching, already have switched in the last years, in the past month, and more to come, particularly speaking about the 10-dose to the 5-dose measles containing vaccine switch. So there are a lot of lessons learned coming out of it on operational guidance and how to, to really manage those logistical aspects, those training aspects, those cold chain management aspects to get those lessons learned from the previous experiences and implement them more broadly to the countries that are in the pipeline looking to switch, planning to switch. And yeah, Ethiopia, I think, is a great example, and a lot of momentum is being seen in Ethiopia, and I think it will also generate a lot of lessons learned for other countries in the region across the continent as well. Thank you.
Thanks so much, Amina. So Thelma, I see you've got some questions on the Q&A. We're going to type answers to your questions now, including GEM. Sidi, if I may ask a question to you briefly, in terms of NITAGs being able to access, to initiate the switch, advise their Ministry of Health on undertaking the switch, how much information do you think NITAGs currently have in terms of the options available for the vaccines that they could consider for the switch? Do you feel that currently there is enough sources of information readily available for NITAGs to make a decision related to the switch? And if not, do you see that there could be more partnership with Gavi and other partners in terms of having to understand this portfolio of vaccines that could be crucial in guiding NITAGs on decisions related to switch? Sidi?
Yeah, thanks, Ben, for this question. I think this is an issue in discussion. In September, there is a workshop in Tunisia where we were discussing on the new vaccine introduction, prioritization, and vaccine optimization. So in at the global level, there is a project of having a compendium of evidence for new vaccine introduction and product optimization. And I think the switch is a component of that. And so for the African region, so we are in discussion with some partner like the NGF and GSI to how to implement and disseminate these new tools in the region in the coming year. And I think I will reach out to you when all this will be really fine-tuned, and so for the support from Nish. Over.
Okay. Thank you so much, Sidi. I see we're running out of time for that past session and Q&A. So we're going to move to the next session, which is emerging evidence from the field on vaccine switches. And we're going to have 3 speakers. Kate Hopkins from Sabin is going to start talking about the hexavalent. And then we're going to have Constance from Zambia EPI. You had Maggie mention about the Zambian study on the MCV10 to MCV5 switch. And then finally, we're going to hear from Aaron Wallis on the Ethiopian field experience. So may I ask the speakers to just, go stick to 10 minutes. And after that, hand over to the next speaker. And then after that, we're going to have Q&A. Over to you, Kate. And first introduce yourself. Thanks.
Sure. Thank you so much, Benjamin. I appreciate the opportunity to speak with you all today. My name's Kate Hopkins, and I am a director of research for the Vaccine Acceptance and Delivery Initiative at the Sabin Vaccine Institute. We're a global NGO based out of Washington, D.C. And I am currently directing a Gavi-funded project with a consortium of partners to assess the hexavalent switch in the first Gavi-eligible countries. Let me share my screen. Hopefully you can all see my screen.
Yes, Kate, we can see your
Okay.
screen. If you can just put it on. Perfect. Excellent.
Wonderful. Okay. So again, just want to give a shout out to our wonderful consortium partners. So that's eBase, Effective Basic Services based in Cameroon, Makerere University, the Task Force for Global Health, and World Health Organization, AFRO, WHO AFRO, and Citi is here with us today. So I'm going to walk you through kind of current status regarding vaccination coverage and recommendations, the case that's being made for switching to hexavalent vaccination, and then talk a little bit about this assessment project that I had previously mentioned. So first, talking about kind of WHO and then African RITAG recommendations. Currently, the WHO recommendation for countries using OPV and IPV are 3 doses of OPV and 2 doses of IPV. For countries using IPV only, the recommendation is that there's a 3-dose series starting at 6 to 8 weeks at 4-week intervals. And if starting at 6 weeks, a booster dose should be given at 6 months or more after the 3rd dose of the primary series. And then regarding DTP, WHO recommends 3 booster doses following the primary series. So where are we coverage-wise? Obviously, suboptimal, as I'm sure you all know. Global IPv1 estimated coverage for 2023 has gone down since 2022 with suboptimal coverage in the African region, where 21 countries have low IPV coverage. There are 36 countries total that have yet to introduce IPv2, and 58% of those countries are in the African region. And then regarding DTP, 44 countries don't have any of the 3 recommended boosters, and nearly all of those countries are in Africa. So WHO and the RITAG have reinforced the importance of attaining high IPV coverage and urge all countries to either introduce IPv2 or rather hexavalent vaccination without delay. So Citi did a wonderful job of kind of outlining all of this in his presentation, but just wanted to say from December 2023, countries eligible for Gavi support can apply to switch to wholesale pertussis containing hexavalent vaccine, which is 6-in-1. It's the DTP, it's the Penta, DTP, influenza type B, Hep B, and then also adding IPV into the mix. So 6-in-1 rather than the Penta plus IPV. And so since 2000, over 90 high-income countries have already switched, and countries in Latin America have already been implementing the acellular pertussis containing hexavalent vaccine and will switch to wholesale pertussis in Q1 of next year. Global studies report that introducing hexa vaccine reduces the number of injections, and that improves immunization compliance, resulting in increased vaccine coverage of its components. There's also potential cost savings. I realize in Amina's slide, that benefit wasn't ticked because we really do need to gather more evidence around this. Hexavaccines are typically more expensive than the pentavalent vaccines, given coverage of more antigens and the production requiring more advanced technology. But we really need to drill down and gather evidence in this to see if, there's a cost savings across direct and indirect costs. So they could provide direct cost savings due to programmatic efficiencies, such as fewer healthcare visits, less staff time, decreased shipping, handling, storage costs, and potentially reduce vaccine wastage and disposal costs. And with increased vaccination scheduling compliance, there can come a decrease in infectious disease risk, outbreak and emergency response, and costs associated with illness. Indirect cost savings relate to parent time saved, traveling to health center visits, and other societal costs. So again, it's important to consider both direct and indirect costs, indirect being societal and opportunity costs, when comparing hexavalent and pentavalent vaccination programs. And then other benefits are supporting the polio eradication program, in that it greatly facilitates integration of IPV into routine immunization, and then other aspects of strengthening immunization programs, specifically as it relates to booster platforms. This just shows the decrease in injections, so going from 6 to 4, and we've heard that helps with compliance and helps combat any parental vaccine hesitancy relating to the number of injections, which is helpful. I just wanted to share that most evidence out there currently is affiliated either with high-income countries as the setting, or acellular pertussis containing hexavalent vaccines. So there's still a lot more evidence that needs to be gathered as we move into hexavalent vaccine switches for whole cell pertussis containing vaccination in low and middle income country settings, and especially in the Afro region. However, considerations are thought to be similar between acellular pertussis containing and whole cell pertussis containing hexavalent vaccines, such as they can be co-administered alongside other vaccines, such as PCV and measles, and the real-world safety and immunogenicity profile is similar. So this slide just shows a study that does have the whole cell pertussis containing hexavalent vaccine. It just gives a couple key findings from a phase 3 randomized controlled trial of safety, immunogenicity, and non-inferiority of the whole cell pertussis containing a vaccine against the whole cell pertussis penta plus IPV. And in short, it found that the whole cell pertussis containing hexa vaccine was non-inferior, well tolerated without any safety concerns. But again, there needs to be a buildup of the evidence base. So this brings us to, as I had mentioned, we need to gather a lot more evidence in the neighborhood, in the Afro region, especially because that's a lot of switches will be implemented in this next year and the coming years. So that brings us to the Gavi-funded Hexa Switch Assessment Project and its HEVAC, or Hexavalent Vaccine Switch Assessment Consortium, Saban-led consortium with all the partners mentioned on the first slide. So the overall aim of this project is to explore mechanisms to support enhanced decision-making, implementation, monitoring, and impact evaluation of the multi-step switch from penta and IPV to hexavalent. There are 3 objectives. The first 2 objectives are focused on a kind of a deeper dive into 3 countries that will be the first Gavi eligible countries approved to implement next year and in 2026. And then the third objective is a broader cross-country learning opportunity and capacity development opportunity across kind of a broader network of countries that include countries considering the switch in coming years. So the first objective focuses around the impact of the switch on IPV and DTP vaccination coverage rates, polio eradication goals, vaccination of 0 dose and under-immunized children, as well as collating lessons learned in establishing and strengthening DTP containing vaccine booster platforms and direct and indirect benefits seen in other immunization programs. The second objective focuses on kind of two main areas. The first one being identifying and understanding enablers and barriers in introducing and scaling up distribution and uptake of the hexavalent vaccine from supplier, implementer, and beneficiary points of view. And then also assessing actual costs and comparing them against the estimated costs across diverse settings, both across countries and within countries. And this piece is really important because it could potentially inform Gavi policy, co-financing policy. And then the third is really piloting a cross-country support mechanism using a NITAG and EPI country twinning process, or we're using that as a cohorting approach for implementation, monitoring, and decision-making processes, and to document the lessons learned, because this is new territory. And so kind of jumping in more around objective 3, which I believe would be most useful to this audience, is just kind of sharing our cohorts and what we have planned for this objective. So we have identified 4 different cohorts regarding the countries in the African region that we know have either applied and been approved, have applied and are awaiting approval, or will apply at various points next year or in the coming years. So there are 4 different cohorts. In cohorts 1 and 2, we have a few countries where they have already been approved, and their action plans are that they will implement, begin the introduction of the hexavalent vaccine between July and Q1, July of 2025 and Q1 of 2026. And then cohorts 3 and 4 are that they're applying next year, and cohorts 4 maybe towards the end of next year or beyond. And there's a lot of learning that can be shared amongst these cohorts, and bi-directional learning really between cohorts 1 and 2, which are the cohorts that will be first out of the gate, and then sharing lessons learned to cohorts 3 and 4. So we've been very busy gathering information from cohorts 1 and 2, meeting with NITAGs and EPI and other stakeholders to understand their NITAG recommendation process, their decision-making process, that the Gavi application process and experience, and gathering that to help support cohorts 3 and 4. And then as implementation is ongoing and we start collecting that evidence, cohorts 1 and 2 can start learning from each other in real time, and then also share lessons learned to cohorts 3 and 4. And so a lot of live engagements will be occurring. We've already had a couple webinars to try to formalize this process, and then we will get going with more routine engagements from next year. And that's all I have, and thank you. I believe, Constance, I'm handing directly over to you.
Thank you very much, Kate. I'm Constance Takalabanda, working within the immunization program as an immunization specialist, but also serving as secretariat for the ZITAG. So I'll quickly go into the presentation. So the presentation is on the rationale and evidence of vaccine switches in Africa. But in the case of Zambia, we shall focus more on the MR that was presented. That was presented earlier in relation to the study. Okay. Just to get a confirmation that my slides are moving.
Yes, you're good, Constance. Please proceed.
Okay.
Thank you.
Thank you. Yes. So we'll look briefly at the overview of switches in Zambia. Then we shall move to the background of the switch from the 10 to the 5 dose. We shall look at the local evidence for the switch, and I won't focus much on the findings of the study as they were covered in the earlier presentation. Then we'll look at also the ZITAG process on the MR switch. Then we'll also look at what they had recommended from there, and also the process of the Ministry of Health adopting that recommendation. Okay, so Zambia has conducted several switches, and our first switch was that mandatory switch from the DPT to the DPT HIB in 2004. And our most recent switch has been the switch from the Rotarix to the Rotavac, and we're pending a switch from the Rotavac, which is the frozen formulation, to the fully liquid formulation. So since the establishment of our ZITAG in 2016, we've had our processes on any vaccine-related issues, including the switch, tabled to them, and they were part of that recommendation process of the switch from the 10-dose to the 5-dose. Then other switches that we have under consideration around relooking the initial recommendation around the PCV switch, and there are also discussions to table the hexavalent switch before them. So we have our timelines for the different switches that spoken to the earlier processes around the DPT to us finally getting to the pentavalent. Then we also had in 2016 the switch from the TOPV to BOPV, which was mandatory. And this didn't involve any of the ZITAG processes. Also, our switch from the measles only to the measles rubella came in at the time that we did not have the ZITAG. But from the time that the ZITAG was established, that was in November 2016, we've had all the discussions around the switch tabled before the ZITAG. So again, just to speak briefly onto that study that informed the switch from the 10-dose to the 5-dose, we had Zambia switch from the 10-dose to 5-dose in 2022, and this was following the ZITAG recommendation in 2019. So prior to that, we had this study that was conducted in 2 provinces, Luapula province and Central province, and we had in total 14 districts that participated either as intervention and control through the process. So we had them participate, and that was with support from a project that was funded by BMGF and led by JSI. So we're very happy to have had at least that opportunity to have the local data available to inform the switch. So this was presented in terms of the finding. Of course, 6 components were assessed, and the findings were as was earlier shared. So now getting to our ZITAG process. So we had the ZITAG process be informed by them looking at our coverage. So they had an opportunity to look at our vaccination coverage from the time that we introduced. So they focused on the MR. So they looked at the MR vaccines from about 2000, but the main focus was around 2013 when we introduced the 2nd dose, just to also see how we fared with both the 1st and the 2nd dose. They looked at the issues around wastage, adjusted vaccine price, supply and cold chain consideration, health worker perception and behavior, issues around equity and social considerations, vaccine registration and regulation, cost-effective analysis, programmatic considerations, and the cost per dose. So we had the MOH policy question around whether Zambia should consider switching from the 10-dose to a 5-dose. The tools that we used during the process were an adapted NITAG recommendation framework, and we also had them incorporate some weighting around the parameters that they considered for this recommendation. So the recommendation process, as I mentioned, focused on the criteria reflected in the diagram on the right-hand side. So also the weighting of the different criteria was based on the level of priority for consideration. So they assigned some weighting onto these parameters to be able to come up with their recommendation. So the ZITAG recommendation was that we needed to consider the switch to the 5-dose because it had a potential and they were more concerned with our MCV2 coverage, which has been suboptimal from the time that we introduced. And their view was that if we were to be looking towards elimination, it would be good to consider strategies that would be able to help us attain those goals. And that would also have an attached cost effectiveness. Then the second was around they noted the hesitancy of healthcare workers to be able to open the vial with the larger multi-dose vial policy, and they recommended that having a lower dose vial policy was more likely to have the health workers willing to open these vials and would be more convenient for both the health worker and the client that would be coming for the vaccination. Because I think even from the study and also from the technical support supervisions, it was noted that clients were being turned away until they met a certain number for a vial to be open. Then they further also indicated that for the SIS, the country needed to consider continuing with the 10-dose vial presentation, taking into account the issues around cold chain space and also the fact that we would have multiple children, more children coming through for the SIA compared to the routine. Then they also noted that while the switch was one of the interventions, there was need for other health system strengthening interventions that would address the suboptimal coverage of the MCV2. So they had indicated that there was need to also ensure that other health system strengthening initiatives were not left behind to the thinking that the switch would address solely the issue around the suboptimal coverage. Then they had further highlighted that there was need, they noted that in the provinces that were considered, there were quite a number of rural districts, and so there was need to also consider conducting a research in high volume urban facilities, so in some sort of parallel setting where there would be consideration for a 10-dose and a 5-dose to be implemented using that parallel system. So that was one recommended study that also came out of the ZITAG recommendations. But this is yet to be undertaken, and I think just to request for those that are considering any implementation research to also consider this recommendation by our ZITAG. So from the adoption process, well, once that recommendation was issued, the report was submitted to the Ministry of Health, and there was that adoption of that recommendation in 2020, but we're only able to fully operationalize the switch in 2022 through a phased switch. One of the considerations for this delay was that there was need for that lead time and communication with UNICEF to be able to plan for that switch and securing commodities to be available. And at the time, we were told that there was need to plan for not less than 1 year before the switch, and so we had that delayed switch. And because we still had valid doses of the 10-dose, the switch had to be undertaken through a phased manner. So in the interim between the switch and that recommendation, we had to ensure readiness. So we were able to conduct that focused supply planning with UNICEF to secure availability of the doses. We had also to ensure that there was preparation of the appropriate training materials for the subnational levels, as well as conducting a cold chain assessment to see that we had adequate space for the switch. Though through the study, we noted that the issue of the capacity was less likely to affect the lower levels, but we needed also to assess the upper levels and make any adjustments with that focused supply planning. So when we implemented that phase switch, the switch was completed with all the districts completely switching by the end of the Q3 of 2022. I'll end there. Thank you very much.
Thanks, Constance. And now we go to Aaron Wallace.
Thanks so
But
much.
again, Aaron, if you could just spend a minute to introduce yourself. Thanks.
Sounds good. Greetings, everyone. My name is Aaron Wallace, and I'm an immunization technical officer for WHO headquarters. And I will be presenting on the Ethiopia measles 5-dose study on behalf of the study collaborators. I was a co-lead for this study when I was with US CDC a couple of years back. So very similar to the work that you've been hearing from Zambia and highlighted in previous presentations, for Ethiopia, this conversation on switching to 5-dose started roughly 10 years ago. And Ethiopia was quite interested in doing implementation research to develop their own evidence on switching to 5-dose. They also wanted to look at the use of an open vial policy in the country, so pairing this with a switch to 5-dose. The open vial policy being a policy that encourages the health workers to prioritize coverage over wastage. And there was also an option looking at the pairing of this open vial policy with provision of more 10-dose measles containing vaccines. So we developed a cluster randomized controlled trial. You'll see in this box here at the bottom the two different interventions that I described. First was a training only group, which was trained on, health workers were trained on this open vial policy. So actively supporting the open vial policy that encouraged the health workers to open up a measles containing vaccine vial for any number of children present, whether it's a 10-dose or a 5-dose. And in this group, they were provided more 10-dose measles containing vaccine vials to ensure that they were not concerned about wastage. And then we had an intervention group that we called the measles 5-dose group that followed that same active support for this open vial policy and then a switch to the 5-dose. Our primary aim here was to understand the effect of the interventions on measles first dose and second dose vaccination coverage. We have a secondary aim to look at timely measles vaccination coverage with our underlying theory that with a switch like this, reducing missed opportunities for vaccination, children will get an earlier, more timely vaccination for measles. And then we have tertiary aims that looked at health worker practices and costs. So I'm going to jump into the results here and run through the results of the study over the next few slides. On our first slide that we're looking at here is the change in measles first dose vaccination coverage. What we saw here was actually for our 5-dose and training intervention group was a relatively small net change in measles vaccination first dose coverage of 0.5%. So it was not something that reached statistical significance in our study. We didn't see any impact on measles first dose coverage from comparing the training only intervention group to the control group. However, for the measles second dose vaccination coverage, we actually saw a fairly substantial and statistically significant increase in measles second dose vaccination coverage, a net difference of 17 percentage points higher in our 5-dose and training intervention group. In our training only group, we saw no statistically significant difference. It was a 4% difference between that training only intervention group versus the control group. So the conclusion here being that we were seeing this impact for measles second dose coverage, but not for measles first dose coverage. Now, for measles first dose vaccination timeliness, we did see a statistically significant improvement in the more timely delivery of a measles first dose vaccination for our children who were in the 5-dose training group. On average, they received a measles first dose vaccination 30 days earlier than those children in the control group. In the comparison to the training only group versus the control group, we again did not see a statistically significant improvement or change in measles vaccination first dose timeliness. For our analysis where we looked at measles vaccine wastage rates, one of the important things to note for Ethiopia is they generally have two major types of health facilities. They have health centers, which are the larger facilities, and health posts, which are the smaller ones. The health posts tend to provide a fairly substantial proportion of the vaccinations. Those are the facilities that are much closer to the community level. And this is an important stratification here that we make because typically those health posts will have much smaller target populations, and also where you're going to see this challenge of health workers being hesitant to open up a measles-containing vaccine vial for children that does not show up on a scheduled measles vaccination day. And also where you're typically going to have a smaller target population in general, and you're going to observe higher measles vaccine wastage rates. So what we saw here when we compared our 5-dose health facility intervention sites to our control group was that in the health centers, we saw a 9 percentage point net improvement or decrease in measles vaccine wastage rates. And for the health posts, we saw a 12 percentage point net decrease in measles vaccine wastage rates for our 5-dose intervention facilities versus our control intervention facilities. For the trainee-only group, we had hypothesized we would see an increase in measles vaccine wastage rates because we were telling those health workers they could open up the 10-dose vaccine more frequently, and we did end up seeing an increase in that measles vaccine wastage rate in those health centers, and then a relatively little change for the health post level. For the analyses that we looked at for health worker practices and caregiver experiences around these measles-related missed opportunities for vaccination, we observed that the health workers reported that their frequency of turning children away on a non-measles vaccination day was much less frequent in both of the intervention groups. 60% of those health workers indicated that they would not turn a child away for measles vaccination on a non-measles vaccination day, whereas in the control group, only 15% of those health workers indicated that they would not turn a child away on a non-measles vaccination day. So basically, we're seeing this statistically significant improvement in the proportions of health workers who indicated that they would vaccinate a child anytime they came for measles vaccination. And then for the scheduling of measles vaccinations, we asked them about how frequent they scheduled measles vaccination days. This is something that even for the 5-dose group is still a common practice. And in the control group, nearly all the health workers indicated that they would only schedule measles vaccination days 1 to 2 times a month. But in the intervention groups, we saw a decrease in this proportion of measles vaccinations days only being planned 1 to 2 days a month. Only 50% of those intervention health workers indicated that they would do so. The other 50% indicated that they were conducting measles vaccination days much more frequently, as upwards of every day in those more heavily populated health facilities. For the caregivers' reported experiences on missed opportunities for measles vaccination, we saw a positive change in the proportion of the caregivers that were reporting missed opportunities for measles vaccination in the intervention groups. The proportion that were reporting this in the intervention groups decreased by 50% from baseline to endline, whereas we saw no change in this proportion of caregivers reporting a missed opportunity for measles vaccination from baseline to endline in the control group areas. For what we did for the financial costing scenario for this particular study is we costed out a hypothetical national level switch from 10 dose to 5 dose using the study results here. And what we estimated based on this, this financial projection is that the country would observe a 5% lower decrease cost in the cost per measles dose administered, and a 15% lower procurement cost in per 2-dose child if they were to switch from 10% or 10-dose vial to 5-dose vial. And this was largely driven by the fact that our study was showing that a switch to 5-dose would have a positive impact on measles second dose coverage, on improved MCV1 timeliness, and on a decrease in MCV1 or MCV wastage rates. So this table down at the bottom just summarizes the key results from our Ethiopia study. I won't go in detail here, but just to highlight what we saw is the positives for a switch to 5-dose from our study was we saw a significantly higher increase in measles first dose timeliness, a significant increase in measles second dose coverage, reduced measles vaccine wastage rates, particularly in the smaller facilities, a slight decrease in the cost per dose administered if one switched to 5-dose, and the health workers and caregivers reporting fewer measles-related missed opportunities for vaccination. On the more negative side, we saw no major positive impact on measles first dose coverage, and we saw a minor increase in storage requirements, but again, they're a relatively minor increase that's from the countryside was deemed to be fairly reasonable. Some of the considerations that came out of our discussion across all the partners involved in this study were the importance of the vial opening policy, that a switch to 5-dose needed to be accompanied by also a writing or reinforcement of a vial opening policy that enables the health workers to open any size measles-containing vaccine vial, and that this policy needs to be well disseminated out to the health workers and the supervisors so there's a good understanding and a following of this policy. We saw that the switching to 5-dose enabled the health workers to reduce missed opportunities for vaccination. This was something that we saw for both of the intervention groups, both the switch to 5-dose as well as just following the policy. And there was a potential here, I didn't show the results, for such practices of not turning parents away to yield better parental attitudes about health services being received, as you can imagine. And then one note here on the context for Ethiopia, it has generally pretty low measles vaccine wastage rates in the control groups. We observed for those health facilities anywhere between 20% for the larger health facilities to closer to 30% for those health posts. And the 5-dose switch, it did reduce the measles vaccine wastage rates in the intervention group that had the 5-dose. However, for those countries where baseline wastage rates are higher, a 5-dose switch could provide much greater rate reductions, which would also translate into much greater cost savings than what we've calculated here for Ethiopia. So what happened next was this study was overseen by a Ministry of Health technical working group made up of all the in-country partners who stayed in constant contact with the progress of the study. And when the results came out, they were reviewed and there was internal MOH supports for using the evidence to consider a 5-dose switch. And the Ministry of Health led the presentation to the NITAG for consideration, which was endorsed by the NITAG. And now, as I understand it, on the Ethiopia side, the Gavi switch application is in progress. And I think that's it. I'll hand it back over.
Okay, thank you very, very much, Aaron, and thank you to the three presenters during that session. All three excellent presentations. Just before we move on to the Q&A, I just wanted to very quickly introduce myself. My name is Anne Burton. I'm a Senior Technical Officer with the Australian National Centre for Immunisation. we are working very, very, very closely with a number of NITAGs in the Asia Pacific region. And we're also a partner on the niche-led MCV switch project. So there's one question so far. This is to Constance. Thank you for the presentation on the Zambia switch. Could you please tell us how the switch was done? Was it a nationwide or was it progressive? And what plans were put in place to manage waste, since the number of empty vials to discard increased? Constance, could I kindly ask you to respond to that question, please?
Thank you very much for the question. So the switch was nationwide, but it was in a phased manner. As the districts utilized the 10 dose, they then switched to the 10 dose. So they then switched to the 5 dose. So it was nationwide, and right now through routine, we only have the 5 dose that is being used everywhere. So it was a phased but nationwide. Then in terms of how we managed the waste, seeing that this now increased the number of vials that we would have to discard, I think from what we noted so far as a program is that there wasn't a significant increase or strain on the available waste management facilities, other than the challenges that were noted even before the switch. So we didn't have any additional or significant changes in the waste management practices. Thank you.
Great. Thank you very much, Constance, for that. So given that we are running behind in time, then we'll move on to the next two presentations. But please do put your questions in the chat, as there will be a short time for questions after the next two. I would like to hand over to Elizabeth from Niche. Thank you.
Elizabeth, you're muted.
All right. Thanks, Nina. All right. Good afternoon, everybody. My name is Elizabeth. I am an evidence-informed decision-making specialist and research officer with Niche. And I'll just jump right into my presentation. I would like to acknowledge all the speakers before me. They've done an excellent job, and they've made my job relatively easy. Sorry, just a second. Let me turn off my camera so that it's, yeah, thank you. So then I'll share my screen. Let me just do this again. All right. Sorry, I seem to be share. Okay. Yeah. Yeah, can you see my screen?
Yes, we can. If you could just put it in presenter mode.
Yeah, I'm trying to do that. All
Thank
right.
you.
Thank you too. So the topic of my brief talk is on evidence gaps related to the MCV 10-dose vial switch to the 5-dose vial switch. And I have 3 brief sessions to present what we know, how we learned it, and why further investigation is necessary. So what we know. All the speakers ahead of me had alluded to the fact that we do know that the summary of it is switching from 10-dose vial to 5-dose vial for MCV is very, very beneficial, both to the caregivers, to the healthcare workers, to the government in terms of cost, increased coverage, increased timeliness. And currently, about 18 countries, depending on how you count them, had switched. And as Maggie showed in a slide, much more improvement can be, much more gain will be obtained if more countries switch. I'll just zone in on maybe 2 countries, not Zambia. Let's just take a look at DRC to see the evidence that ensued from that country's context, when they transitioned in September 2022 from MCV 10-dose vial to MCV 5-dose vial. They saw that wastage decreased significantly by an estimated 5 to 10 percentage points just in the first few months of the switch. And there was no strain on the existing infrastructure, logistics infrastructures to accommodate the 5-dose switch. Equatorial Guinea also had made the switch, and they are currently using the 5-dose vials for routine immunization of both measles and yellow fever. And they also reported increased in timeliness and in frequency of sessions. And we are still looking to have more evidence come out of that. So this is just to add to all what had been previously said. And then in the second session, just one slide, and I would like to acknowledge Maggie Archibald in absentia for graciously producing and giving me these 2 slides. How did we learn all those things that we know? We learned them by conducting studies, by conducting research, and several research had been conducted. I mean, we've learned from the Zambian study, from the Ethiopian study, and several are ongoing. For example, the US CDC and the Laos Ministry of Health have an implementation research ongoing that the results is expected to be made public by the end of the year. And there are also some retrospective studies ongoing on the continent. And there are also some that are forthcoming, to which my colleague will speak to later. Now, this is really the crux of my presentation. If we know that switching from 10-dose measles-containing vaccines vial to 5-dose measles-containing vaccines vial is undeniably advantageous, and several research had been planned or had been conducted that confirms it, and there are some that are ongoing and others that are planned, then why is further investigation still necessary? And this also speaks to the graphic of that slide that I've been using consistently as my section divider. Number one, knowledge is fluid. It keeps moving. So as evidence is emerging, evidence gaps are equally emerging. And that is why we need further investigation to, 1, identify these gaps, and to 2, plan ways and actually go beyond planning, but actually implement ways to address them. So one of the reasons why further investigation is necessary is to correlate the pre and post national rollout findings in countries like Zambia and Ethiopia that had done, pilot studies pre the national rollout. We need to correlate those findings to find out if what was actually predicted was actually what obtained, when it was rolled out nationally, and to gather documents and data in real time. So we need prospective studies as to track in real time the rollout for the MCV switches. We need to explore the seemingly gray areas that some pilot studies identified. For example, Aaron spoke to the fact that for the Ethiopian study, the impact on the second dose was significant, but not for the first dose. So that's an evidence gap. Why? That needs to be explored further. Then also to investigate and document the relationship between NITAGs and academic institutions in the switch process. Of all the studies that had been conducted, except for probably the one that Kate spoke to that is yet to be implemented, the dynamics of the relationship between NITAGs and academic institutions have not been documented. Nina, I see your hands is raised. Do you want to shoot now, or I'm almost done? To investigate long-term cost effectiveness of the switch, also to garner evidence that will facilitate improved policy implementation. Aaron also spoke to that extensively about the open vial policy. Also, we need to conduct further investigations to map changes in healthcare workers' knowledge, attitude, and practices across different contexts, and to facilitate improvement of available tools, development of new ones, and their optimal usage. But the most importantly, we need to share emerging good practices and value add. And that is what the planned study that my colleague will speak to very soon, that's one of the biggest value add to all the other studies, and to addressing the evidence gaps that still exist in our knowledge of switches from 10-dose vials to 5-dose vials. So this is just a screenshot of proposed user journey mapping, which eventually will be made available to countries, and they can adopt it for their own context, and it will help them to document their journey from the pre-switch era to the monitoring and evaluation post-switch era, and hopefully make their findings publicly available so that more countries will be encouraged to switch, and there will be less zero-dose children, as Maggie indicated in our presentation. So with that, back to you, Anne, and I'll take the questions both in the chat as well as live. Thank you.
Thank you very much, Elizabeth, for that really excellent presentation. I think we'll, if it's okay with you, we'll move on to Naina and then do the questions together at the end. So Naina, over to you. Thank you very much.
Okay, thank you, everyone. Okay, so I'm Naina Menga. I'm a project manager at Niche. I work with Elizabeth and Ben. So I'm going to share my screen. So let me know if you can see it. Okay, can everyone see that?
Yes, we can. Thank
Okay,
you.
great. So thank you to everyone for staying. So today I'm going to be talking about a project which is funded by Gavi to generate real-world evidence related to measles-containing vaccine 10-dose to 5-dose vial switches in Africa. This project is, sorry, I'm just trying to get the next slide. This project is the result of an RFP that was put out by Gavi at the beginning of this year, and it was to look at the project which Kate spoke about earlier today on the hexavalent, as well as the MCV programs. So in response to the RFP, VACFA reached out to other groups within the University of Cape Town as well as outside to develop a project proposal. And as a result, we've included people outside of Niche and VACFA. We've included people from the School of Public Health, Health Economics Unit, as well as Epidemiology and Biostatistics. We also formed the measles vaccine containing impact consortium with NCIRS, and the moderator is from NCIRS in Australia and Linksbridge in the States. The title of our project is Measles Containing Vaccine Presentation Switches, Impact, Experiences, Cost Effectiveness, and Lessons Learned. So just to give some background to why measles is so important. Measles is one of the 6 childhood killer diseases targeted by the World Health Organization with the Expanded Program on Immunization, the EPI. And since then, a concerted effort has been made to increase MCV coverage, and that's seen a drastic reduction in disease burden globally. The WHO estimates that between the year 2000 and 2023, there's been a reduction of 60 million deaths due to measles. But there's still persistent low coverage due to missed opportunities, vaccine wastage, stockouts, and healthcare worker and caregiver behaviors, among other factors. Just last month, the WHO published a report saying that last year in 2023, there were 107,500 measles-related deaths, mainly in children under the age of 5 who were unvaccinated or undervaccinated. There were also about 10 million cases of measles globally. So and they're also seeing, as a result, intermittent global outbreaks and disease resurgence, often in low and middle income countries. The CDC has reported that there are currently measles outbreaks globally, and the interruption of vaccine programs by the COVID-19 pandemic resulted in more measles outbreaks. So the problem that most of the speakers before me have addressed is that healthcare workers can be hesitant to open 10-dose vaccine vials for fear of wastage or stockouts, as the vaccines have to be used within 6 hours of reconstitution, and this hesitancy results in missed opportunities to vaccinate children. So the switch from 10-dose to 5-dose vials is an approach to increase vaccine coverage. Vaccines are exactly the same in formulation, reconstitution, storage, and handling, delivery, and waste management, as well as WHO pre-qualification status. The only difference is the packaging. So why 5-dose vials? Again, we've just, the study is, our work protocol was based on the available data at that time, which came primarily from the Zambian study, which is Constance has outlined. It was because it was healthcare worker friendly. There was less hesitancy to open vials and vaccinate children outside of scheduled times. It also had positive effects on vaccination coverage. Supply chain was able to accommodate the increased storage requirements. There was a 47% decrease in wastage, and it was cost effective because the increased cost was only 3 American cents more for 5-dose vial per vaccine. So our study fits into the broader scheme of implementation reviews that are being done or have been done. Elizabeth outlined a lot of them earlier. So our study is going to contribute to the evidence generation to support and guide MCV switches as well as other vaccines. We're going to be looking at 3 countries, 1 retrospectively and 2 prospectively. And at Niche, we are really more interested in helping NITAGs, so we're going to be including an objective that will help NITAGs. So the primary objective of our study is to measure the impact of MCV 10-dose to 5-dose switch on the coverage of both first and second dose at national and subnational levels to generate information for NITAGs especially. We're going to be using a mixed methods approach. We've got 4 objectives. One is to generate or collect quantitative data looking at coverage, and second, qualitative data looking at healthcare workers, knowledge, attitudes, practices, caregivers' behaviors and beliefs. Objective 3 would be looking at health economics factors such as wastage, costs, etc. And our 4th objective is to find information that will help NITAGs to identify challenges faced by local groups to inform vaccine decision-making. So my final slide is to say where we are at the moment. And what we've done is we've developed a generic protocol. We're selecting our study countries at the moment. And once the countries are identified, we will work with the NITAGs and EPIs from the countries to identify the key stakeholders who will help co-design the protocol. And then we'll obtain the authorizations to conduct the study in the countries. Thank you for your attention. Thanks, Anne.
Thank you very much, Naina, and thank you very much to Elizabeth. Both of those presentations contain lots of information in a very, very short time. So thank you to you both. So we have just a very short amount of time for questions. I see that questions are being answered in the chat. So there's one question. This is, it's actually directed to the Ethiopian program, but it's a general question. Please, can you share the cost of purchasing MCV dose 10 and 5-dose vials, and if possible, MCV 1-dose vial? So I'm wondering if one of the panelists from the last session would like to answer that, or one of the other panelists would like to answer that. Look, the reason for the question is looking at storage space is a great consideration. Single-dose vials for MCV may have a place for handling some of the challenges that have been presented talking about MCV.
So is Wale still on the call?
Yes, he's still, yeah.
I'm still here. I'm just looking. So in terms of the actual vaccine cost, which we basically are getting from UNICEF's supply division, I can I can put into the chats the sources, but typically the 5-dose cost is, I think, roughly 5 or 10% higher per dose versus the 10-dose vial. But I know that there's been a lot of work being done around trying to reduce that cost per dose for 5-dose versus 10-dose. For the Ethiopia study, we accounted for on our financial scenario of a nationwide scale-up calculation did account for that higher initial cost per dose for purchase of the 5-dose versus the 10-dose, and still saw that improvement in cost per reached child, mainly because of that lower vaccine wastage rates that was being achieved by the use of the 5-dose, as well as an increased MCV2 coverage. One thing I'll note too is under our own calculations there when we were doing this, there was still not available a 5-dose vaccine vial that is now actually available, which is a actual physically smaller 5-dose vial compared to the 10-dose vial. At the time, the 5-dose vial was physically the same size as the 10-dose vial. So our storage calculations are a bit on the high side versus what would actually be required now for a country that would be switching to 5-dose, since there's now available a slightly smaller physical vial size for 5-dose.
Thank you very much, Aaron. And you wouldn't happen to know the 1-dose vial? The participant was also asking about the 1-dose vial and whether or not there was a cost comparison for that. The single-dose vial.
The single-dose vial is, I know it's substantially more expensive, and just looking here on the UNICEF Supply Division side here, there's, from my understanding, for single dose through UNICEF Supply Division, only MMR vaccine is available. So we don't actually have a specific UNICEF SD pricing. At least that's my understanding for MR or M only vaccine for single dose, just given kind of the usual sourcing that's needed for different countries and what they would typically be using.
Sure. Okay, thank you very much. I don't think there's any more questions. So thank you very much once again to all of the presenters for those really, really rich presentations and giving us a lot to think about. I know that we were particularly wanting, to hear from countries that might have been considering the switch. So, certainly there's been a lot of information that's been presented today to help with those deliberations. So I'll hand back to you now, Ben. Thank you very much.
Thank you so much, Anne, and thank you so much to the speakers and to you all participants for staying with us despite us going 15 minutes past the hour. We appreciate. I think we needed to discuss as much as possible, but in hindsight, actually, we should have possibly cut 1 or 2 talks just to allow more time for discussions. We're going to have these presentations and recording available on the NICH website. And if there's anything that you may want to reach out to, let us know. We can link you with the speakers for further engagement. And we look forward to working with you in supporting the continent, conduct the switches that are going to be quite useful in strengthening our immunization program. So thank you, everybody, and particularly to our speakers. Thank you very much. And to our moderator, Anne, we appreciate. Keep well and have a wonderful day all evening. Thank you and bye-bye.
Thank you all. Bye all.
Thank you very much. Thank you. Bye-bye.